Second day of the tutorial after an exciting first day. So we're really looking forward to the second day, and we'll make a start now. It's a pleasure to invite Dr. Siddiqui to start the proceedings for the day.
Assalamu alaikum and good morning, everyone. It's a pleasure to be here in Lahore, which is almost like a second home for me. And it's again really nice to be with you all. I'll start with thanking the International Academy of Cytology, as well as the directors of this course, Dr. Ali, Dr. Loya, as well as Dr. Madassar, for being such gracious hosts as well as organizers. So with that, let me start out with my first presentation today talking about urine. So it's again really impressive to see a big turnout. So talk about urine, which is basically a waste product. So that's basically what people have been telling us about. Why do you even look at it? Especially some of the most seasoned uh, surgical pathologists, not in this audience, but that has been some of the feedback I have gotten. So the journey today would be highlighting and updates of the urinary cytology, which I have gleaned over with my experiences in the last 10 years or so of having worked with the Paris system. And let's see a show of hands. So, who finds urines, looking at them, evaluating them, and then giving out a diagnosis as a very easy task? Anyone? No. So, there's a resounding no. Well, I'm glad to hear that because I had a planned, canned answer for that. So, you're not the only ones. And that's what exactly led to this whole journey. In 2010, American Urologic Association, big powerhouse of urologists. They have an annual meeting in Dallas. At that time, at least, they used to have it. And I was one of the few people who was actually a cytopathologist who was present at that meeting. I was based out of Southwestern at that time, and I had the pleasure to be participating in the proceedings of that clinical meeting. Person after person coming to me was just giving me this feedback. You guys, basically, they used the a real bad word. You're not delivering. The ATPR rate is very high, and we are going to discount most of your reports going forward, and we'll actively try to not have it as part of our management protocol. I mean, that was a big red alert for me. I mean, our volumes are for non-gynecologic cytologies were fairly high for urine cytology, and that would have meant doing away with a significant segment of our workload. Obviously, it would have had ramifications for teaching as well as revenue generation. So, based on that red alert, I was not the only one. Other individuals who were cytopathologists were hearing the same feedback. ATPR rate is just too high. So, that was the bell ringer for this great success story, which going forward almost 13 or 14 years afterwards, we can call out as the Paris system. So basically, I mean, in 2012, a group of us got together in Paris, and that's why the name the Paris system. The International Academy of Cytology's Congress over there. That was the reason we were there. It was spearheaded by Dr. Dottie Rosenthal as well as Eva Wojcik, who essentially are powerhouses as far as written literature goes and on the topic. So they were the key individuals, and along with them, there were other notable individuals present at that meeting. I think there were about 10 of us in the room, and essentially that was the founding basic foundation was set up. So the goal over there we decided was what is it really that is needed, and what is it that we can really truly deliver. So essentially, when we talked about the urine cytology, the key thing that the urologist needed from us was giving a reasonably sound diagnosis of high-grade urothelial carcinomas. That was the main premise, number one. Number two was deliver a system which would refine what atypia meant and basically reduce the rate of atypia on urine cytology, and deliver a report which was more substantially useful for them for management purposes. So that was basically the goal of that group, small group. And guess what? Who was tasked the assignment of delivering on the high-grade urothelial carcinoma chapter? Yours truly. So I had the task of kind of coming up with the diagnostic features along with a team. And obviously, I had a lot of support from my group. Some of them were seasoned pathologists, and some of them were basically not so senior, which included some of my upcoming residents as well as my fellows for doing basic legwork for literature review and kind of tabulating the data that was available for us to use. Stone atypia, this is really one of those confounders where the term is applied as a comment in our specimens under the umbrella of negative for high-grade urothelial carcinoma. Here, clinical information is very important. Clinical history, if lithiasis is mentioned or given out to you, it would make your life a little easier. But the key is low NC ratio with pycnotic nuclei, which are really dark staining. If you find chunks of, calculi still, as you can see over here in this corner there, that is exceedingly rare, but it makes it very easy to still call this as negative. But again, depending on your practice, if you're not comfortable with making this call, the authors from the Paris system do recognize that if this is noted in your samples, you can flag this as atypical. But I would recommend still using the term low-grade negative for high-grade urothelial carcinoma as your mainframe diagnosis here. Treatment effect, again, can be a confounder. Radiation change, we all know what those changes are. You can come across quite a bit of cytoplasmic vacuolation, amphophilia, which is two-toned appearance of the cytoplasm. NC ratios tend to be on the lower side. That's the key over there, but bizarre forms can be noted. Similarly, granulomatous change, this is usually noted after BCG immunotherapy. And again, I don't really need to further highlight what BCG change looks like to the group over here. So this is, again, when you note this, not to be flagged out as atypical, but as negative for high-grade urothelial carcinoma. Question about non-urothelial cells. Occasionally, we may come across some of these, such as what you can see over here. There's a little bit of pigment, which is yellowish in color. So this is lipofuscin, and this is basically representing seminal vesicle. There are some spermatozoa over there, which I would not really flag out in my report. But again, there is one consideration. If there is evidence, if there is a clinical question of retrograde ejaculation, then you have to flag these out. Why? Because recurrent infections, that's the key, and that this has to be investigated in that context. Ileal conduit, again, very easy to recognize because once the patient has had a surgery, post-cystectomy, urinary diversion is created. This is basically made out of the ileum. So this is not urothelium, but rather basically coming from the GI tract. These are constantly sloughing off. Urines tend to be acidic. It depends on the pH value. So obviously the enteric cells are not used to this milieu of low pH. The pH of the urine can range anywhere from 1 to 14, 1 being the most acidic and 14 being more, basic in appearance. So if it's more acidic, you'll have constant sloughing off. So ileal conduits can be really quite a challenge. Why? Because what they are looking for is upper tract recurrences. And again, use your criteria. The cancer cells tend not to survive much in this environment. So when they do, you need to look for viable cells. If they are not there, then obviously this is still going to be called out as a negative for high-grade urothelial carcinoma. Guar bean. Anyone knows what this is? What's a plant structure doing in the urinary tract? So that's what this is actually. You can see a very prominent nucleus here. Over there, some inflammation. So this basically is an example which you may see in patients who've had surgery and they have a stoma. To cover the stoma, an adhesive is used, which does have a component of this gauer bean plant material. And at least in the US, we do encounter these frequently in such patients. So again, it's something that you need to recognize and know. Again, just it's an outlier scenario and may not be necessarily part of your practice. So again, at least be cognizant that you can sometimes see elements such as these in your samples. So again, if you see this, no atypical cause, just call it negative for high-grade urothelial carcinoma. So this is a summation of the negative category. Final thoughts that this implies that the specimen being reviewed does not contain any findings that would significantly increase a patient's risk of high-grade urothelial carcinoma. So this has really helped us as practitioners of reducing our atypia rate, mainly because previously materials such as gauer bean, also polyoma virus, they were all being flagged out as atypical calls, and we have really been able to hone in on this aspect of the atypia calls that were previously being rendered. So thus the negative category is not really a waste basket, but we really have what I would call eliminated the waste over here. Moving forward, let's talk a little bit about atypia before I really describe what an atypical call should be. If you look at this graph over here, this is really well illustrated. Non-disease samples and disease samples, and this should be the range that we should be looking for the domain of atypia. I mean, this is a fairly easy concept to understand. Overlapping values, that's what this is, that when we can't really tell whether this is non-diseased or diseased appearing cells. So that's basically the concept here. What can increase this atypical call is basically reparative change, degeneration, poor preparation, lack of experience in handling of these specimens, and the list goes on. So again, this is a conceptual review of what atypia should be, but main thing is that this atypia should be honed in. We really need to exclude all the conditions that I have mentioned before as part of the atypical calls and render them more in the negative categorization, such as polyoma, stones, or therapy effect, and even tissue fragments which are noted in voided urine. So again, we have really been able to chip away from this, and still we do need this category because there are individuals who do want to use this, and rightfully so, because still there is a subset of cases where we really cannot tell what some of these cells really mean as far as clinical context goes. So this should really be reserved very specifically to urothelial cells which are viable. They should have mild to moderate cytologic change that is concerning for high-grade urothelial carcinoma. Now, this is a very kind of still a nebulous categorization, and it's very individual dependent also in many ways. But again, you have to figure out what your threshold is for what mild to moderate cytologic atypia is. It should not be intense. It should not really have really profound appearances as far as a consideration for high-grade urothelial carcinoma should be considered. So we have NC ratios, NC ratio of 0.5, or meaning thereby that 50% of the cell is occupied by the nucleus. So that's your NC ratio. And then along with that, search for nuclear hyperchromasia. As you can see in some of these cells, the chromatin can be coarse with an irregular chromatinic rim. So these are basically the criteria with nuclear hyperchromasia, coarse chromatin, that should alert you to the presence of these atypical cells. But again, it's very dependent on an individual's own thresholds. So you'd use it judiciously and only in the context where you consider high-grade urothelial carcinoma as a remote possibility based on mainly the patient's history. These are some of the examples that can be illustrated as truly atypical. You can see that almost all of them have NC ratio, which is slightly above that what you would expect in benign appearing cells like 0.5 or slightly higher. Chromatin is still more on the coarser side, but again, it's not intensely coarse, and the atypia is somewhat mild to moderate, ranging from more milder elements noted here to a little bit more profound here, and this could be considered as moderate. So for the ones who really are going to use this term, use it judiciously, and these should be a benchmark for you to use for an atypical call. So effect of the first parasystem, and based on our survey, what did we find out about atypia itself? Most of the participants said that they were able to reduce their atypical calls. It ranged from lowering from 21.6% from before implementation of version 1 to as low as 15.9 or 16%. So some statistically significant differences there. These are all the list of calls based on published literature. As you can see, this is pre-parasystem version 1. This is the post-parasystem version 1. Every single publication is showing you a reduction, with the most significant coming from the University of Miami group here. Also, the Koreans were able to reduce it quite significantly from 25 to 14. One exception was Charo Granados' group from Madrid, Spain. Theirs went up. So the question has been asked from this group as to what happened. What happened was they changed the processing from, I believe, cytospins to ThinPrep. So again, it was a learning curve that came into play, and that's why this publication's still out there. So what did yours truly do in his own practice? This is my, I would say, my clean cut record. 2016, it took a while for us to implement it in Cornell. Couple of reasons for it. I think the main issue was LIS systems, getting them to come on board and then educating our clinicians. So it took us a while. 2016, we started working on it. So these are our numbers. And as you can see, most of them were still negative. Our atypia rate was about slightly over 10% before we actually went live. So in September of 2017, we really implemented it. This is our data here. Still, majority of the cases were negative. Atypia was reduced to about 7.63%. That's the number just over a period between September to December that we really went. And again, these are our raw numbers, about slightly over 8,000 cases per year. 2018 was when we truly were able to observe what our differences were here. Again, the atypia has been reduced to now lower than 3% at this point. So this is basically a very slow process. It required quite a bit of work with our clinicians, with our faculty, cytotechnologists, and having a daily consensus conference and reviewing these cases with my group on a very consistent basis. So where are we with it now? This is the complete data for 2022. Obviously, I don't have the numbers for it for this year. But 2022, we have still stayed stable at 3% call of atypia. And the vast majority of these cases are still being signed out as negative for high-grade urothelial carcinoma. So this is our data. And again, just to illustrate that, at one point, the group was signing out these cases with a atypia rate of 10% or slightly higher, and now it is consistently lower, and we are hitting a 3% rate. A little bit more about atypia, that every time we render this call, the phone rings. And I have learned with time that there are certain clinicians who really want to know a lot more about why we are making this call. And my question to them is, what is it that you really want us to answer? And the answer to that question is, are you suspecting a malignancy? Should I send the patient for cystoscopy? You can ask any patient, especially an elderly man who is headed for a cystoscopy. I think they lose their sleep 2 days before the procedure. So it's not to be taken lightly. There is a patient at the other end. So, and it has quite a few ramifications from patients themselves of having to address other issues when these procedures are being done. So we try to really work hard with both our clinicians and our team as well to keep this ratio at this level, but not at the cost of missing out on cases. Our QA is, I would say, it's pristine because there is follow-up. We have very diligent clinicians, and if they even have an iota of doubt in the diagnosis, significant follow-up is done, cystoscopy is done, biopsies are procured, and then at the QA conference, which we have almost on a weekly basis, we review each and every single case with urines and followed up with a biopsy done within 3 months. So that is how we handle our cases. And it is, I would advocate for it, and I would say it's quite doable, and it does have ramifications. Suspicious for high-grade urothelial carcinoma, again, this is not really a wastebasket categorization. It's very much there, and I'll tell you why. Because both the risk of malignancies obtained by rendering this diagnosis are significantly different from when we make a call of atypical or straight out high-grade urothelial carcinoma. So this is a distinct category that should not be discounted but still be used. Again, I would say judiciously. So this should be only done when you don't have a reasonable specimen, both based on qualitative and quantitative metrics, to make an outright call. That's basically what you would think of from that perspective. Again, numbers are important. The qualitative measures should be looked at. Both these things account in making this call. So again, you have to look for non-degenerated viable cells. The cells tend to be of a high NC ratio, greater than 70% of the cell surface being occupied by the nucleus. And then along with this increase in NC ratio, at least two of the following features can be noted. Hyperchromasia, which should be, in contrast to the atypical categorization, should be moderate to severe. And then along with that, irregular coarse or clumpy chromatin or irregular nuclear membranes, if you find either one of these, then that should really be a reason to make a call of suspicious for high-grade urothelial carcinoma. So what are the numbers you should be looking for? Because again, it's a game of numbers. If you have quite a few of these cells, then you can make an outright call. So for upper tract cases, such as renal brushings or washings, then you should look for at least 10 cells or less. But for bladder washings or voided urines, 5 or less would be your number. So it's a game of numbers here, along with matching qualitative metrics such as hyperchromasia or coarse chromatin or irregular nuclear membranes that you are looking for in your samples. So this is what would make you use this category. But aside from these main criteria, there can be other features that can be noted on individual cases, such as eccentric placement of the nucleus, prominent nucleoli, necrosis, and pleomorphism. Again, these are features you all know would be noted in cases which are indicative of a malignancy. Some examples here. Basically, you can see that if this is the only grouping of you would find in your sample, just 4 cells here or so, giving you NC ratios which are on the higher side. coarse chromatin, irregular membranes. And this is actually a fairly classic example, a single isolated cell here in a background of blood, which is indicative of hematuria. Look at that NC ratio and look at that chromatin, very coarse, really rough appearing. And then basically the nuclear membrane will really make you complete your call for giving it a suspicious for high-grade urothelial carcinoma call. This is again another example. The numbers are low here. This was the only group, that was the only cell that was noted with the features that I've already described in detail. So both qualitative and quantitative measures are accounted for when you render this diagnosis. This is a little different, certainly looks ominous, but look at the cytoplasm, it's already disrupted. So because of that, this is degeneration. You can certainly think of malignancy, but do not call this as a suspicious call. If I would actually probably place it as a negative case here based on the degeneration here, but if you are so inclined, it's certainly allowable to call it as atypical. And this is from comparison purposes from the suspicious categorization. You can look at the atypical, truly atypical cells. These would be what would be called out with irregular nuclear membranes and a higher NC ratio, but no hyperchromasia was noted in this example here. So the prevalence of the suspicious category is still on the lower side. We are hitting it at about 3%, but in the literature, it can range to up to 6.6% of a given practice. It's still a very small percentage of urinary cytology. And this is really kind of giving you a complete picture based on literature review that the risk of high-grade malignancy for the suspicious category is clearly distinct from the atypical as well as the outright malignant categories. So this is at 80 to 89% based on the 4 studies with the highest number of patients with histologic follow-up. If you take all studies, which are about 18 in the literature in the last 10 years, again, it's a distinct category here from the atypical and the high-grade category, and certainly can be utilized based on that fact alone. So coming to the goals of the Paris system, this is the high-grade urothelial carcinoma categorization. This was the goal, and a goal with no plan is just a wish. So I had to make it happen and achieve this gold standard. So these are some of the images and the definitions we came up in the initial first version. Take a look at it, self-explanatory over here. It's a very cellular sample. Malignant cells are there, very high NC ratios, very classic appearance of a high-grade urothelial carcinoma, and a little bit more on it. But here, these are just examples over here to give you an idea of what the images look like. NC ratios, take a look at them. Look at the nuclear membranes, look at the chromatin. These are the 3 elements you need to kind of focus on. Very self-explanatory, and this should never be a problematic call. So this was the original criteria that was listed in Paris 1.0. It has not changed significantly at all in version 2. We need at least a minimum of 5 to 10 malignant cells, depending on the location of the sample coming. NC ratio should be 0.7 or greater. Moderate to severe hyperchromasia. Nuclear membrane should be irregular in appearance, and chromatin can be coarse and clumped. So when the specimen is cellular, it's really not a problem. I mean, at low power, I mean, no one has to tell me that this is not malignant. It's fairly classic call over here. A lot of malignant cells. Do I have to apply those criteria on these individual cells? Would I do that if I saw a frank outright adenocarcinoma or a squamous cell carcinoma? Probably not. So this is basically fairly easy to recognize. When it's cellular, it's there, make the call. This is what NC ratio looks like, 0.7. Like I said earlier, 70% or higher should be comprising of the nucleus within that cell. This is the intensity you can expect to see to represent hyperchromasia, fairly classic. Again, here the nuclear membrane irregularities are noted. These are not well defined or smooth. You can clearly see them in their various configurations here. But again, outline is very, very irregular. And this is what coarse and clump nuclear chromatin is. So this is your baseline when you are looking at your specimen sample, whether it's shore path or thin prep or even a cytospin. These should be representative of all these individual features. Of course, sometimes you can see divergent differentiation, such as squamous differentiation in a background of high-grade urothelial carcinoma. The high-grade cells are there. These are clearly malignant and displaying squamous differentiation. So these are some elements that you can still encounter. Background has high-grade urothelial cells. Then there's cytoplasmic differentiation. This represents glandular differentiation. So follow-up of regarding high-grade urothelial carcinoma after the first edition. Of course, successfully implemented criteria have been honed in by various groups, and some of the things that, like I mentioned earlier, that anecdotally telling you about them from different people is questions came up about NC ratio, about degenerative cytoplasmic features, hypochromasia, and the subtypes that they were not included in the first version. So that's what we have worked with on the second version. But going back to the first version and its outcomes, we also found that some of the morphology-based assessments for NC ratios can be challenging for individuals, because if 0.7 is a benchmark, then how do you differentiate between 0.5, 0.6, 0.7? And this is a really good chart. You can actually download it from the book, or it's available even online based on the publication here, and you can set it up on your next to your scope and compare these images for your individual cases. So this would be a good benchmark, what 0.3 is and what 0.8 is, but this is what we are calling as 0.7, and more on this. So can digital image analysis help us? It certainly can. However, how many people have that available in their practice or have the time to use it on, say, 100 cases on a day? In some practices that can happen. So again, it has its utility to address NC ratios. This is a study we did, and again, we did confirm that with digital analysis, most of these cells were displaying an NC ratio which was actually lower than 0.7, but we did find at least 5 cells in each of these samples which had NC ratios which were higher than 0.7. So again, that illustrated based on image analysis that the cancer cells are not static in appearance as far as NC ratios go. They can have a range here, but we did have to give a benchmark. So that's why we selected 0.7 as our benchmark. Degenerative changes can really confound the problem, because some of these cells will show the nuclear features of malignancy, but because of degeneration, the cytoplasmic volume increases. So that can lower your NC ratios. So again, that should be accounted for. And again, degeneration, if it's present, it should not really make you make an outright call for malignancy. You need to really downplay on these cases and back up to a suspicious call if needed. So this is the summary for the second edition here, that criteria for cytologic diagnosis are internationally accepted and successfully applied in most practices. We have recognized that NC ratio, we are flagging 0.7, but it's not a static number. Most cases will have a range that you would encounter from sometimes really low to much higher NC ratio. And then degenerative changes have been mentioned as something to look out for. And then hypochromasia has also been recognized as a very rare occurrence and a potential pitfall in diagnosis, because if we are using hyperchromasia as a benchmark, then how do we recognize this? And then high-grade urothelial subtypes have also been described, and an attempt has been made to kind of corral them together in our criteria. So this is basically now the new cytomorphologic criteria of the second edition. Is exactly the same, except the question came up, what is 0.7 or greater as far as NC ratio? So I actually really wrote this up whole sentence here: cross-sectional area of the nucleus occupying or equal or more than 70% of the cross-sectional area of the cell size. So no discussion as far what NC ratio and 0.7 or greater means. But the other criteria are still kept the same. And why have we done that? More on that, but again, want to recognize the variance in the size and shapes of these cells. So these are all my cases from my own practice. You can see there was a concurrent biopsy on each of them. Look at how low the NC ratio is. But with the help of the nuclear details I highlighted, you can still make a call of high-grade urothelial carcinoma on these. Here, the NC ratios are way higher than 0.7. This is really a tight, cohesive group. Similarly, in these cells individually, slightly dispersed here. And over here, there's also a range from low NC ratios to high NC ratios. So again, there is always going to be a variance in NC ratios on your samples. So do not fixate on that 0.7. It is to be used as a reference point for your practice for making an outright call, but do recognize that there's going to be a whole range of NC ratios in your given sample. But to keep the specificity of your diagnosis on the higher side, use your benchmark of 0.7 and look for at least 5 to 10 cells if it's a lower or upper tract sample. So those are some of the things I want to mention. Again, variance in NC ratio should always be accounted for. This is quite a bit of information here. I can always give you this handout, but look at the last line, where the cells of interest all have NC ratios of less than 0.7. What do you do with those cases? So those cases can be placed in a suspicious category, thereby preserving high specificity, but also indicating to the treating physician the likelihood of malignancy. So that's how you would address if the NC ratio criteria has not been met in your given sample. Degenerative changes, like again, can be noted depending on the practice as well and how the specimen has been processed. Cytoplasmic vacuolation or degenerated cells do not account for making an outright call. I just want to kind of hone in on this fact. You should always back up to a suspicious call if you need to do that. You need at least 5 to 10 non-degenerated malignant cells to make an outright call. So again, be cautious, because first-time diagnosis of high-grade urothelial carcinoma is fairly significant on cytology, and degenerative changes should always be accounted for. Hypochromasia. So this is really something I was not noting in my practice at all. I mean, we use thin prep. So again, that is alcohol fixed tissue samples that have been processed as a cytology sample. So you can take a look at it here, that these are coming from a cytospin sample. So this is a little different. Hypochromasia is noted there, but at the same time, NC ratio for most cells is very high, and the nuclear membrane is giving you quite a bit of irregularity. So this is again easy to recognize as cancer, but with our criteria, that can be a challenge. But if you look at this sample here, over here, you can see majority of cells have hypochromasia, but then there are at least 5 cells with hyperchromatic nuclei, which would again help you in facilitating a diagnosis of high-grade urothelial carcinoma. So hypochromasia by itself is an exceedingly rare event. When you have it even as a predominant cytologic appearance in your sample, then you should still look for in the background for few hyperchromatic cells. By and large, you are going to find them, and then you apply your criteria and then render a diagnosis of a high-grade urothelial carcinoma. So that is how I would make that call. Histologic subtypes of high-grade urothelial carcinoma. So remember, there are 14 subtypes of high-grade urothelial carcinoma. Some of them are really rare. how can I put all those together for a cytologic process? I mean, this was just not possible. And again, I want to flag out two subtypes, the micropapillary urothelial carcinoma and plasmacytoid urothelial carcinoma. These were the most challenging to kind of fit in. So for these, what I would recommend is be aware of the WHO classification system, be aware of these subtypes all listed here from the 2022 WHO book. Remember, most of your cases are going to be conventional urothelial carcinomas, and with our criteria based on the Paris system, you should be able to make a confident diagnosis very easily. It's basically the micropapillary carcinoma, which tends to stuff off as really very small cells. So you have to look at them not just at low power, go at a higher magnification. The micropapillary will give you micropapillary configurations with high NC ratios. Similarly, the other problematic one is the plasmacytoid urothelial carcinoma, where the NC ratios are on the lower side, even as low as 0.3 for your malignant cells, but the nuclei will give you a complete understanding of what it is, and that is it is malignant. So these are outlier situations, and again, what I want to focus on is the conventional urothelial carcinoma as what we have to address. You need to be aware of the subtypes, and if needed, use the Paris system judiciously, but you can still work outside its listed given criteria if you're familiar with the various subtypes. Luckily for us, these are rare instances. To find that picture of plasmacytoid and as well as the micropapillary carcinoma, seriously, I mean, I just had maybe 2 cases out of the, I think, 8 times 5,000, cases we see in our practice. So again, it's a very rare instance that you are going to encounter that. So this is basically, again, I think I've already discussed it. Be aware of these subtypes, and they may not fall in the classic criteria that are illustrated in the Paris system. Fibrovascular cores, it was interesting that a lot of people wanted to know about the relevance of fibrovascular cores. Like I mentioned, it's a very rare instance, but again, in the context of benign appearing cells which are adherent to these fibrovascular cores, like I mentioned, that goes into the negative for high-grade urothelial carcinoma category, with a comment saying that this most likely represents an L-gun. But if it is a high-grade cytology that you are noting along with these fibrovascular cores, then again, focus on the cells and not on the fibrovascular cores, because the criteria laid out by the Paris system would apply to the cells, and fibrovascular cores there are certainly there to help you, and you can completely understand that it's a papillary configuration based on that. But again, focus on the cells and not the fibrovascular cores. They really don't play a relevant role when there are cells which are of high-grade cytology adherent to fibrovascular cores. Cytopathology of the upper tract, there has been a separate chapter, but what I want to say about this is that in a summary, for high-grade urothelial carcinoma, apply the same criteria. It's just the numbers that you have to be cautious with. Again, look for at least 10 instead of 5 malignant cells which are viable and non-degenerated. If you have those, that should be enough for you to be able to make a call of high-grade urothelial carcinoma in the upper tract samples. Again, with upper tract cytology, we can be very focused on right versus left renal or ureteral disease. So that is very helpful sometimes, which basically bladder washings or voided urines may not be able to identify. So that's known as selective cytology. And that has been further described in this additional chapter in Paris 2.0. Other malignancies, primary versus metastatic, this is a long list, and I'll briefly go over these with you, but again, most of you can probably easily diagnose these. Non-urothelial malignancies, are mostly epithelial in origin, and less so sarcomas or lymphomas are found here. They certainly can carry an aggressive behavior, and you certainly have to recognize whether these are primary to the bladder or the urethral tract, or they are coming from elsewhere. So squamous cell carcinoma, second most common malignancy of the urinary tract after high-grade urothelial carcinoma, should have pure squamous differentiation. If it's a keratinizing squamous cell carcinoma, it's an easy call to make. Again, it's the non-keratinizing squamous cell carcinomas which can be very challenging, because there are overlapping features between a non-keratinizing squamous cell carcinoma, say with a comparative example of high-grade urothelial carcinoma. It can be quite a bit of challenge and may be impossible at times. So again, just a word of caution here, look for some spindling. This certainly can be noted in the non-keratinizing squamous cell carcinoma, but can also be noted in high-grade urothelial carcinoma. So this would be a difficult call, and you need to be kind of aware of that. Again, primary versus METs. This is also important because, especially in female patients, genital tract primary malignancies can invade into the bladder and present themselves as pure squamous cell carcinomas being detected in a urine sample. So again, be cognizant of this. Atypical squamous cells certainly are to be noted in your reports. If they are found, if they are not necessarily representing malignancies, they should be certainly identified, because certainly if they are noted, they can be basically a harbinger of malignancy which is yet to be discovered. So certainly that is something for a urologist to be aware of, and they can work up the case further. So this is an example. You can see if we find this in our sample, this may represent something such as this, where there's a urothelial carcinoma, but this surface layer here is giving you frankly keratinized appearance. So again, this is again where we really help the urologists out quite a bit in following up with these patients. Low-grade squamous atypia. So what is cytology doing here? These cells do find their way in urine samples, which may resemble, frankly, low-grade squamous intraepithelial lesion or high-grade squamous intraepithelial lesion, as noted in the cervix or vagina, or even in anal cytology samples representing HPV change. You can certainly find them in your samples. You still need to list these when you find these as under the umbrella of negative for high-grade urothelial carcinoma, and this can be flagged as L cell or H cell as a comment. So that's something to be noticed. And a little bit more as far as what atypical squamous cells can look like. But main thing over here is, if you don't have enough cells to make an outright call of squamous cell carcinoma and you have few cells, then you can certainly create a suspicious for squamous cell carcinoma or high-grade urothelial carcinoma with squamous differentiation report. And that would be sufficient for the clinician to use as a guiding light for further management. Adenocarcinomas, the next malignancy, pure glandular differentiation, primary versus METs. Again, for this group, primarily of cytopathologists, should not be very difficult. Main thing is to recognize that prostatic adenocarcinomas can find their way, colorectal carcinomas, and even sometimes breast carcinomas have been found in urine samples as metastatic disease. Small cell carcinomas, really rare tumors. Classic morphology, small cells, they're basically 3 times the size of a lymphocyte. There would be molding, and then salt and pepper chromatin, although not obvious in small cells, but again, really that's the key over here. And then you can certainly confirm it with IHC if need be. Risk of malignancy has been addressed, and this is a list of them. You can see the main ones that we really want to focus is the non-malignancy groups, which are basically negative for high-grade urothelial carcinomas, a very low risk of malignancy there. And then we are really doing well with the malignant category here, with the risk of malignancy listed it as here. So that was a very fast and rapid review of the Paris system, the journey starting in 2012 and culminating in where we are in 2023. But I just want to flag out that the journey is not complete. We are still going to be moving forward with collected data and literature and working on the next version, which should be coming out in a few years. And what I really foresee is that artificial intelligence is probably going to play a big role in it. And that is something that we would have to focus on in the future, along with imaging modalities, because essentially glass slides may be not be used in the distant future for sign out purposes, but rather images on the microscope that we would be signing out on. So these are some of the issues that we would be contending with and may have an impact on the Paris system, and we would be incorporating that. So we have a few minutes and let's have some fun here. I mean, probably not so much fun for some of these patients, but certainly as practitioners and as individuals who sometimes have to figure out these difficult puzzles that fall in our practice, sometimes on a daily basis. So this is the first case. 70-year-old gentleman presents with retention of urine, a bladder washing was performed, and we got about 50 ml submitted to the laboratory. This is what it looks like at low power. I have had a very busy service on this day. This is my first impression. It's very cellular. I think this would be an easy call. There are two fields over here, really adjacent to here, illustrating that there are groups of cells, not quite well adherent, but kind of clustering together. But in the background, there are single cells. They certainly appear to have a high NC ratio. And I mean, on a busy day, urine number 51, I think I'm good for making an outright call, right? Intermediate magnification, what an easy call. Focus on this cell here, quite high NC ratio, maybe some necrosis in the background. Some degeneration certainly is noted, but at the same time, some of these are viable cells, single cells, some tight groups there, maybe some spindling here, but look at this one. This is the best one here and here and here. Highest magnification. My 100x didn't work that day. So this is, I think, at 60x, and take a look at these cells. This is a good example here, here, and here. Almost every single cell is displaying the same features, which are high NC ratio, somewhat coarse chromatin, and I'll stop there. So this is the categorization. Show of hands, who thinks this is negative for high grade? Atypical? High grade urothelial carcinoma. No one's agreeing to high grade? Or is this something else? No. No history. No radiation. So one thing I didn't mention was the nuclear membranes. Take a look at this carefully here. Nice and round. And this is a real case. I mean, this was from last month. And I mean, I was a little stumped as well what to do with this. But again, the more you look at it, and this is the final diagnosis, polyoma infection. So based on the clinical information I had, the patient was immunocompromised, and basically looking at these cells, what was the issue was that the NC ratio and low power magnification, that majority of these cells were displaying the evidence of polyoma infection. Generally, you find isolated cells. You don't find cells in this great a number. which was actually the detractor here. So basically, that's the key over here with polyoma virus infection, that when you do find it, you ordinarily will come across with a few cells with very high NC ratios, washed out chromatin. I mean, because of an inclusion there, there's margination of the chromatin, which gives you a very clear appearance, very basophilic. So these are some of the features you look at. But to compare this with a high-grade urothelial carcinoma cell, your best bet is the nuclear membranes. Look at the nuclear membranes. If they are smooth and well defined, you can comfortably make a call of this being a negative case with infection going on, essentially noted in patients who are immunosuppressed, and that is something that would be helpful with the history. Sometimes these are named the decoy cells. The term was coined by Andrew Ritchie. He was cytotechnologist in Sloan Kettering across the street from us, and it reminded him of decoys, which are used in duck hunting. So again, this term has been used mostly in the books that have come up after this was initially coined, the term. So that's something that you need to look for. Now, there will be situations where you are going to encounter polyoma with high-grade urothelial carcinoma. They would be distinct, and it would again be the nuclear membranes that are going to help you the most in making a judgment call of separating them. So we have another case here. This is a 62-year-old female with hematuria. It's voided urine. So background is there. I mean, there are some umbrella cells, individual cells, but this group really stands out. There is gland formation going on. You can see that here. Some hobnail appearance of the cells, flat sheets. Here there is three-dimensionality, but the cytoplasm is a little bit more abundant there. And this is still very much at a low power, and you can clearly recognize that this is a pathologic process. A higher magnification of those two images, again, illustrating some glandular differentiation with NC ratio, which is quite high. Here, these cells are giving you a different morphologic appearance. The same cells, but the gland formation is missing. The cytoplasm is a little bit more abundant, a little bit more clear. NC ratio is still very high. And still a higher magnification here. Look at the size of this nucleus, this pleomorphism, clearing of the cytoplasm. Over there, the same cells, some hobnailed appearance. Same cell, but I started looking at this a little bit more carefully. I found some proteinaceous material too, a little confusing, but again, you kind of pass over this so far till I started looking at it in some of the cytoplasmic details when I looked at it at a higher magnification. And this is degenerated group of tumor cells with, again, this proteinaceous material. So obviously these are cancerous cells. Can I make a diagnosis? If I can, how should I slot it? Sorry? I think I heard the answer from the audience. Non-urothelial, I think you are right on track. So this was a real gutsy call. We called it clear cell adenocarcinoma. Based on the appearance and the presence of the protein. And again, it's something I was aware of. That's why I thought of it. I mean, I had seen cases on biopsies as well as resections. Again, it's a very rare entity. My year of fellowship at Anderson, I did have a case. So that's what reminded me of, and I made this call. Was I right? This was the follow-up. So 1.8 centimeter urethral tumor was resected. Look at the configuration here. I mean, there are strips of these tumor cells. They have a very hobnailed appearance, and then clearing of the cytoplasm there with very large nuclei and prominent nucleoli. In other areas, the morphology was the same as what was encountered in the urine sample. But again, the proteinaceous globules are there. This is again a real significant hallmark which is noted in clear cell carcinomas arising from the urethra. So PAX8 and cytokeratin 7 was performed on the resected sample. Both came back positive, PAX8 being strongly uh, nuclear stained and cytokeratin 7 giving you a cytoplasmic staining. So again, this is a real rare entity. And again, I just want to illustrate the fact that rare tumors can be encountered. I don't want to really propagate zebras to be found in urine samples on a daily basis, but just be aware that these are conditions that you may have to work with, that you may encounter unusual malignancies in your specimen samples. For this particular case, the example is fairly well illustrated. It's a classic triad, basically, of papillary configurations as well as hobnailing, and then accompanying with proteinaceous accumulation in the cytoplasm. So I think we are doing well with time. I have 4 minutes to finish. So I have one more case. This is actually a very interesting case, and you will think, why is he showing this? Fairly easy. 81-year-old male with mild hematuria and abdominal discomfort. So fairly low in cellularity. This is a good example of a well-preserved umbrella cells. And then what's all this here in the background? First glance at low power, you would probably just think nothing of it. Okay, there's some infection there. So this was the highest magnification, and so this is basically the highest magnification. So any takers for this? What do you think this is? It is bacteria, and who's the best answer came from the group. This is Sarcina or Clostridium. And why is this important? What do I have to think about here? That I, as a cytopathologist, looking at a urine from a patient, can tell to my clinician what do they need to be aware of. Now, this is really an unusual scenario, but again, if I make a call of Sarcina, they have to work this up further, because gastric obstruction is in the play, because if it's a diabetic, gastroparesis is definitely a possibility, and they have to really follow this patient up. So again, these are tetraform gram-positive bacteria. These basically have to be flagged out, and further workup has to be done. So again, just a low yield specimen such as this, as a routine case with bacteria that are noted in your sample, can yield to significant patient outcomes. And that is what I want to leave you with as a message, that what you do is very important for your patients. And again, you should really be proud and being good practitioners of your craft. If you have stringent criteria that you apply on your specimens, you will really do well for your patients and for your clinicians for excellent management of the samples that you provide a diagnosis on. So if there are any questions, I am happy to take them. Thank you so much for your time, and then we can proceed to the second talk.